Hello from Philadelphia. Thank you for your interest in our presentation, which is on the rapid guidance summaries that we developed for COVID-19 response. Let me tell you a little bit about our center, which is a hospital HTAi center for a healthcare network that has 6 hospitals, almost 3,000 beds, 10 major outpatient facilities, and a staff of about 4,400. We're internally funded by the health system itself. Now, in 2019, our story begins with a new respiratory disease discovered in China. It came to the United States in 2020 in the Pacific Northwest and in New York City. With our proximity to New York City, the pandemic hit our region in Philadelphia very, very quickly. All of this strained our healthcare system considerably. We were running low on critical care beds, ventilators, negative pressure rooms. We were running out of personal protective equipment, and our staff was working long hours and burning out. We had tents set up outside our emergency room for use as triage facilities. Our new hospital pavilion, shown on the left in this picture, was under construction, and we had construction crews coming in, working night and day to finish out a couple of sections of that hospital that we could use as COVID wards if necessary, and an arena in Philadelphia set up as a surge facility to accommodate cases where we couldn't have enough hospital space for. So in the early days of the pandemic, there were a lot of questions that our clinical staff and our administrative staff were asking. How do we treat the disease? What sort of precautions do we need to take when we're treating these patients? When do we know that it's safe for a patient to be discharged? What kind of personal protective equipment can be reused, and how can we safely reuse it? Many, many questions. And under normal circumstances, we would answer these questions in an evidence-based way. Search systematically, find the best available evidence, analyze it, and present it to our decision makers. But this was a situation where none of that ideal evidence could be applied, and the time wasn't available to go and find it. We had urgent needs, time requests, projects completed in days rather than weeks or months. We had no direct evidence about how to manage this disease. There weren't clinical trials of COVID treatments, there weren't evidence reviews, there weren't guidelines. And many of the questions that we were being asked were things that we had not been asked before as a health technology assessment center. The evidence pyramid really looked like this at the early days of the pandemic. Most of what the evidence we had were the best guesses of evidence of experts and early reports from hospitals that were treating the first patients. What can we do with this as an evidence-based practice center? We had a new secondary evidence product called a rapid product summary. We talked about that at the meeting in Cologne in 2019. The rapid product summary was an adaptation of existing HTAi reports that we could use to quickly identify answers about a question and present them to our decision makers. Most of these were relating to new drugs and technologies. The key distinction of the rapid product summary was our limited search on a small set of sources, specifically HTAi reports that were published by ANATA members and by in other databases like those of NICE and CADIF. We took what we learned developing this product, and we did the same thing then to develop a product adapting off-the-shelf guidelines for managing COVID. So where the health technology assessment summary had a closed set of lists of HTAi centers that we looked for, we did the same thing with the rapid guidance summary, that we had a limited set of hospitals and other agencies that were our sources of evidence. Those agencies were WHO, CDC, European CDC, Health Canada, organizations like that. Major professional societies that had issued guidance for managing patients with COVID, peer medical centers in the United States and a few of them in other countries. Most of these were centers that were facing early influxes of cases and had learned from managing those patients. And we soon saw evidence aggregators at the University of California, San Francisco, McMaster, Oxford, and other places. But notice that for these reports, we never searched Medline or Embase or other traditional evidence sources. It would have taken too long to do those searches, and the likelihood of getting useful evidence from those sources, knowing the time it takes to get evidence into the published literature, was going to be very, very unlikely. So our product looked like this. This is the summary page, or at least the top of the summary page. It tells us what the key questions are. It tells us what the answers to those questions are. And it is very upfront about the limitations on what we can and can't say from the evidence. One thing that we learned from working with our executive staff over the last 10, 12 years at CEP is that their time is very, very valuable. And so getting even a few minutes of their time during a pandemic is something that's a privilege for us. And so we need to be able to communicate our information as rapidly as possible and as effectively as possible. And that means putting as much of the important findings as you can right on the front page. Now inside, we started quoting recommendations from those public health agencies, from those other hospitals. And we would typically find 4 to 8 sources that had good answers about what should be done in a particular situation. So this is a piece of a table from triaging patients with suspected respiratory illness. And so we had guidance from the CDC. And if you notice here that those CDC guidelines have a hot link that our end user could immediately find the latest information from. We also had guidance from peer medical centers, like the Brigham, like our own center. And again, we had typically 4 to 8 sources in this category as well, noting that we have a date for each of those so our end users can see which of the evidence, which of the guidance is the most recent, and this put more attention to the recent findings. One more thing that we found that was greatly appreciated by our end users is to put copies of flowcharts and other information that was not easy to summarize in a table to actually just place it in a figure at the end of the report. The initial product wasn't perfect, but it proved to be pretty effective, especially in delivering ultra-rapid responses to the questions that were coming in. It typically took about 2 analyst days worth of work to gather all of that information and put it together, copy it into our template, and produce the report. We also were starting to develop an early understanding of what the evidence landscape looked like. We had a spreadsheet of sources that were checked, and we had found links to other catalogs of evidence that were out there. So things that we learned early on was that there were very little guidance for topics relating to hospital operations, how to set up a triage tent, when to be calling patients back for additional follow-up, when it was safe to have patients come back to the clinic. And because there was no authoritative source on these kinds of questions, we found a lot of variability in practice. Another thing that we found was that a small number of sources, especially the CDC, were cited over and over again by those agencies. And that brought us to something of an echo effect, and we tried to call that out in our report. So we would use our red and yellow and green grading system to identify the evidence that the recommendations that had a small number of basic sources and ones where there was a lot of consistency in the recommendations. Now, to scale up to this, we had research labs in undergraduate medical education that was shut down. And so volunteers were coming to us wanting to be able to help with our work. So we enlisted them and set up an organized team members, some of whom were our evidence gathering team and others were writing reports. We had a standardized methods document, a cloud server to supply keep our reports and other sources on, a dissemination team. So here's what the catalog looked like. It's a list of sources with web links and comments on those so that we could quickly scan through those, hit those links, and get the information from the hospitals that we knew had relevant information. Our department administrator and our communications specialist built a dedicated page for disseminating these reports. It was a pretty smoothly running machine, all things considered. We delivered 3 to 5 reports a week with turnaround times that were simply amazing. We made sure to give the medical students ownership of those topics. That was a learning opportunity for them, not just about the topic itself, but also to see how hospitals are managed and how evidence can be used to guide decisions. Some of those topics, especially the ones about treatment, were moving targets, and we had to update them very, very frequently. Those updates got documented so that our end users would see what evidence was new and what evidence was being withdrawn. Eventually, the pace of requests slowed as we started getting through the worst of the pandemic. There were fewer topics about requests about treatment because good guidelines were becoming available from other sources. PPE shortages were resolved, and we started hearing questions about how to resume our normal hospital work. We, meanwhile, continued refining the product and developed partnerships for disseminating our reports. The evidence landscape was maturing as well. We started seeing randomized controlled trials and other high-level evidence. New evidence clearinghouses and living systematic reviews sprung up. And many of these were the kinds of things that we had really been hoping would be happening 5-10 years ago from now. If you think about what we were talking about in our past meetings were about a new way of delivering evidence to guide practice, it's happening in real time now. And this is what some of the secondary sources started looking like. And because they were doing much better job with this than we would be, and they had put the time into it, it was much easier for us to simply summarize the findings from these local guidelines and these local evidence reviews and bring it to our end users. We had examples of living guidelines. And as eventually the evidence pyramid starts looking like this, where the high levels start beginning to be filled in. So now some of our COVID requests could be addressed with traditional evidence reports, but we continue to try and work rapidly. We experienced a shift away from treatment topics to more operational and process-related topics, plus additional requests from the university having to do with their kinds of events and bringing students back to campus safely. But the advent of vaccination brought a surge in rapid requests in late 2021, which we're still dealing with. So to analyze the topics that we looked at, you can see the breadth of and diversity of what we were looking at, not just primary treatment, but also supportive care, transitions of care, hospital and clinic operations, process of care topics that normally get short shrift in the evidence-based medicine realm, but they were crucial questions that we needed to answer for our end users. So lessons that we learned that we can apply to our regular work. First of all, to always be looking for the best available evidence with the emphasis on available. At times of crisis, we can't wait for clinical trials, for randomized trials, for systematic reviews and other gold standard evidence. We may even have to rely on expert opinion at early stages of a pandemic. Build your methods that are reproducible so that you can have additional people coming in to do your work for you to help in a pinch. Keep your reports short. Remember that your executive's time is valuable, and make sure all of the important information is on the cover page of your report. Look for topics beyond the traditional HTAi roles of assessing drugs and devices. Look at process of care. Look at parts of your health system like the outpatient clinics that may not normally be working with high technology, but still need questions answered, because these are all opportunities to help deliver better and safer care, and at the same time, raise the profile of your center and get more support from your healthcare system. And always remember that the people you ask are going to rise to the challenge. So thank you to all of those people, not just our medical students and our clinical reviewers or our dissemination team, but also to Amelia Flores, our evidence team leader, Nikhil Mull, our center director, and to PJ Brendan, the chief medical officer, who has been supporting us through all of this. So to everybody and the frontline people who've been fighting the pandemic, we thank you, we salute you, and we continue to look forward to helping to serve you.